Hello, everyone, and welcome back. Today we're talking about anxiety and obsessive-compulsive related disorders. Anxiety disorders, as defined by the DSM-5, include a range of conditions with separation anxiety and then generalized anxiety. We're going to talk about specific phobias, panic disorder, social anxiety disorder, panic attacks as a specifier, agoraphobia, and then we have some various other conditions, as you can see on the other side here, as far as substance or medication-induced anxiety, anxiety disorder due to another medical condition, or other specified anxiety disorder, and then unspecified anxiety disorder. So we're not going to address other and unspecified here today, but we are going to go through the others in detail. What does it actually mean to have anxiety, and where does anxiety come from? Well, anxiety is a normal human response, and it serves as an important purpose in our lives. It is a natural reaction to perceived threats, whether those threats are immediate or related to fears about the future, health, or other uncertainties. Ideally, we strike a balance with anxiety. Having too little could lead to apathy or lack of motivation, leaving us stagnant. On the other hand, too much anxiety can overwhelm us and leave us frozen or unable to act. So, anxiety is distinct from fear in that it often involves a cognitive component. It can perpetuate through thoughts and mental processing, while fear is typically more immediate and tied to the fight, flight, or freeze response and the autonomic nervous system. Anxiety often stems from our ability to anticipate or imagine potential outcomes. In healthy amounts, anxiety can be very beneficial. For instance, a small amount of anxiety about failure can help us motivate us to study harder, perform better. However, anxiety becomes a disorder when it's out of proportion to the situation, or it's extreme, or it interferes with significantly with daily functioning. So, over the past several years, anxiety and depression have really skyrocketed due to lots of unknowns, lots of challenges. The world is just changing at a very rapid rate. Also, if you consider the COVID-19 pandemic as well. So, there's just a lot going on that are contributing to anxiety and depression in today's day and age. So, as you pursue a career in the counseling field, you're likely to encounter a very high prevalence of anxiety disorders. And just due to things like prolonged stress and uncertainty around the world in which we live in today. Some key considerations about anxiety disorders is that they are very highly treatable, but they can be resistant to permanent resolution. While symptoms may remit, they often reappear depending upon life circumstances. Anxiety frequently begins in early life and can become intertwined with the individual's personality. These disorders are more commonly reported, though not necessarily more frequently experienced, in Western countries and tend to be reported by both men and women, with some variability in presentation. Anxiety is also comorbid with other conditions such as mood disorders or trauma related disorders. For example, we've talked about this before, anxiety and depression are very, very frequently diagnosed together. You can think of them as best friends. They share a close relationship. Anxiety is about the future and feelings of which can lead to feelings of hopelessness and depression. Depression can then heighten anxiety about navigating life. So, this interplay between anxiety and depression heightens the importance of managing anxiety effectively. If left uncontrolled, anxiety can spiral into depression, creating this cycle that impacts the individual's overall well being and quality of life. Okay, let's talk about the neurological aspects of anxiety. This involves the brain's response to perceived dangers and threats and triggers, which activate that rapid physiological reaction that we've talked about. These responses include sweating, heart palpitation, freezing, blood flow being redirected to the core of the body to protect the vital organs. And the endocrine system also plays a role in this process, releasing hormones that prepare the body to react. Remember that fight or flight. So, as we focus on the brain, when a stimulus is received, it is processed by both the sensory cortex. And then at this point, the brain evaluates whether the situation requires immediate fight or flight response or whether it warrants further cognitive processing. So, this distinction highlights the interaction between primal automatic responses and then more deliberate thought based decisions. So, once the stimulus is processed, the brain determines the appropriate course of action, which is then carried out by the body. This dynamic interplay between the brain and the body demonstrates the complex connection between and underlying anxiety responses. With this foundational understanding of the neurological processes, we're going to talk more about specific anxiety disorders. All right, so we are going to begin with separation anxiety disorder, and this is a condition most commonly diagnosed in childhood. It occurs when symptoms are excessive and significantly interfere with daily functioning. Symptoms of separation anxiety disorder can include recurrent or intense distress when away from home or loved ones, as well as excessive worry about losing a parent or a caregiver due to illness or disaster. Children may also experience constant fear that something is bad is going to happen, like being kidnapped. They may refuse to go anywhere without a caregiver, becoming so terrified that they are unwilling to be a part or engaged in new environments. Other signs include reluctance to sleep away from home or even sleep alone, repeated nightmares about losing the parent or being separated from a caregiver, and frequent physical complaints such as headaches or stomach aches during times of separation. Younger children, in particular, often express their distress through somatic symptoms before they're able to verbalize their emotions or experiences, as they may lack the words to be able to describe their anxiety fully. So, what are some risk factors for separation anxiety? Well, some factors that contribute to its development include life stressors or losses that involve separation, such as a family death or a divorce. Certain temperamental traits, genetic predispositions, and family history can also increase the likelihood of developing separation anxiety. Environmental factors such as experiencing a disaster that leads to separation plays a role as well. Again, we talked about this a minute ago, but in recent years, events like the COVID-19 pandemic have created some pretty unique circumstances that have contributed to the rise of separation anxiety. For example, a child who spent extended periods of time in quarantine or locked down with their parents may now struggle with separation as they return to school or other activities. So many of these children fear that their parent could become ill in their absence, further exacerbating their anxiety. Again, as you enter this field, you're going to be reminded of the evolving risk factors and their impact on the prevalence of separation anxiety disorder. So, how do we treat it? Treatment often includes a combination of therapeutic approaches and, in some cases, medication. We've talked about this before. SSRIs, selective serotonin reuptake inhibitors, such as sertraline, are very commonly prescribed. Therapies can be highly effective, including play therapy, which allows the child to process their emotions through play with the guidance of a therapist. CBT, cognitive behavioral therapy, um, PCIT, parent child interaction therapy, are very valuable approaches. Coping strategies like mindfulness exercises, relaxation techniques, and methods to strengthen the mind body connection can help children become more aware of and manage their emotions. EMDR, eye movement desensitization and reprocessing, can be utilized to assist the child in processing their fears or visualizing being safe when separated from a parent. So, the good news is that separation anxiety is very highly treatable with the right interventions. Moving on to selective mutism. This is often identified when a child begins spending time away from their primary caregiver, such as during preschool or early school years, and it can emerge in later childhood, particularly following significant stressors such as a loss of a parent, an illness, a natural disaster, or other major life events. It's important to recognize that selective mutism is highly context and person specific. This means children or adults with selective mutism may be comfortable speaking in certain situations while remaining silent in others. For instance, a child may be very chatty and humorous with friends, but struggles to communicate with authority figures or in unfamiliar environments. Children with selective mutism can still attend school and they can use alternative ways to communicate, such as gestures or writing. It's also common for selective mutism to co occur with anxiety disorders or language disorders. In cases where language barriers do exist, there may be a fear of being misunderstood or uncomfortable speaking in a particular environment can contribute to this condition. Understanding these contributing factors is key to addressing the origins and context of selective mutism effectively. There is no single cause of selective mutism, but it has been linked to several factors, including trauma, genetics, a child's temperament, high levels of anxiety, neurodevelopmental disorders, and environmental influences. It's important to distinguish between active, willful, and an inability to speak. Children with selective mutism have the ability to speak, but are fearful or unable to do so in certain situations. This often occurs when there are social contexts or specific environments. So, the key characteristic of selective mutism is the recurrent and consistent nature across various circumstances. So, what are the criteria for diagnosing selective mutism? While you may not encounter this often, especially if you're going to be working primarily with adults, it's important to be familiar with the signs so you can recognize it if it arises, or perhaps an adult may be speaking about their child and you can help them navigate the situation. So, the key diagnostic criteria here include a consistent failure to speak in specific settings, which must persist for at least 1 month. This inability to speak cannot be due to a lack of knowledge, nor should it be better explained by a communication disorder. Additionally, it should not occur in the context of autism, schizophrenia, or another psychotic disorder. The condition must also interfere with daily functioning. If it doesn't impact daily functioning, it may not be considered a disorder. Okay, how do we treat it? CBT, cognitive behavioral therapy, is often used to help children or adults gradually build comfort and practice communication skills. One key aspect of CBT for selective mutism is addressing speech anxiety through graduated exposure. There is that individual is encouraged to speak small amounts over time and in various different situations, and the goal is to gradually increase speaking opportunities in a supported environment. For children, we want to reward speaking behavior. This is a common approach, reinforcing verbal communication in a positive way. Psychosocial treatments also include providing educational resources for parents and caregivers, as well as coordinating efforts with teachers to ensure consistency across environments. Medication may be a part of a team based approach, especially if progress is hindered by environmental factors at home or other stressors. The medications used are often similar to those that we just discussed about separation anxiety disorder. Typically, it's SSRIs, selective serotonin reuptake inhibitors. Although medication is not always necessary, it can be a helpful option in some cases. Understanding these treatment strategies is going to be important as selective mutism is associated with underlying anxiety, and it's crucial to consider all possible factors when addressing the condition. Now we're going to move on to phobias, which are characterized by an intense fear that something that is persistent, specific, and out of proportion to the actual danger. In a phobia, the fear is perceived as real, but it often doesn't align with the actual threat. This exaggerated fear can stem from genetic, neurological, or experiential factors, such as a traumatic event, or it can be learned through environmental influences. There may also be genetic predisposition involved. Phobias are often maintained through cognitive processes that lead to behavioral responses, whether or not there is an actual threat. This process is also reinforced by classical conditioning. If a person experiences fear response to something once, they may justify that fear in their mind, solidifying the phobia. For example, someone may develop a specific fear or a severe fear of leaving home after a traumatic event. They may see news reports of shootings or other incidences and use this as evidence to justify their fear of venturing outside. This type of thinking is closely tied to agoraphobia, although we're not going to go into that in detail here today. However, phobias and other anxiety disorders, such as social anxiety, often share very similar features. So, for instance, someone with a fear of heights who experiences a fall, or someone with a fear of flying who hears about a plane crash, may develop a phobia that is sustained by reinforcing experiences. So, these processes help then to maintain the phobia and the fear. We keep it alive that way. Let's talk about social phobia. This is a particularly pervasive condition because it involves a highly cognitive aspect of fear, with many thought processes contributing to the anxiety. The distinguishing fear of social anxiety is the fear of having to perform or behave in front of others, particularly in public settings. This fear can be related to specific situations or contexts, such as performance based events versus social interactions. It often involves the fear of negative judgment or attention, where individuals may spiral into thoughts like, I'm not good enough or I will be judged. In severe cases, this fear can extend to an avoidance of social situations altogether. For clinicians, understanding social phobia is very important, especially, again, we've talked about this as the prevalence has increased since the COVID-19 pandemic. The pandemic had provided a rationale for some individuals to justify their fears and to be in isolation, and now they may feel more comfortable avoiding public places or social interactions. For someone already struggling with social anxiety, these additional fears may exacerbate the condition, potentially triggering or intensifying their symptoms. The fear may become more and more entrenched or even worsen as they begin to avoid more situations, further perpetuating that cycle of anxiety. So, what do we do? How do we treat phobias? Again, CBT, cognitive behavioral therapy, is commonly used to treat phobias, including techniques like cognitive restructuring, which helps the individual challenge and change their fearful thoughts. Dialectical behavioral therapy, DBT, can also be applied, particularly in cases where emotion regulation is a key concern. Exposure therapy, this is a critical component of phobia treatment. It involves systematic desensitization, where relaxation techniques are paired with gradual exposure to the feared object or situation. This is an excellent therapeutic modality for the treatment of phobias. And basically, what we're doing is we're teaching the individual coping strategies and relaxation before exposing them to their fears. This ensures that they have the tools to manage their anxiety, as attempting to expose them without preparing the person and giving them the tools that they need. That may actually make things worse, exacerbate the fear, and potentially cause harm. So, our goal is always to do no harm. Another method I'm not necessarily the hugest fan of, which is called flooding. This involves intense exposure to the feared situation, either with or without relaxation techniques. Modeling is also used to demonstrate how to approach a feared situation, while cognitive structuring helps the individual rethink the fears. So, techniques like guided imagery and visualization can be used to treat phobias, enabling the individual to mentally rehearse their fears before confronting them in real life. Medication is also going to play a role here, especially when phobias significantly interfere with the person's social or professional life. In these cases of social phobia, medications like serotonin selective reuptake inhibitors, SSRIs, or MAOIs, monoamine oxidase inhibitors, are often prescribed to help reduce anxiety. However, it is important to note that the phobia is only considered a disorder when it significantly interrupts daily life. In addition to phobias, individuals may struggle with panic disorder or experience panic attacks. A panic attack is an intense and overwhelming experience where the body enters a fight or flight mode. When there is no real threat, the physical symptoms can also be so severe that the person may genuinely believe that they are a danger, even though they are safe. Okay, so we're going to talk more about panic disorder, which generally falls into two categories: with or without agoraphobia. Panic disorder is characterized by that recurrent and unexpected panic attacks, not just a single incident. It's important to note that someone can experience a panic attack without actually developing panic disorder, so that's going to be an important piece for you to know. Panic disorder involves emotional, physical, and cognitive, as well as behavioral components. Emotionally, individuals experience intense fear, while physically, they may experience symptoms such as heart palpitations or shortness of breath. Cognitively, there is often a focus on catastrophic thoughts about the attack, and behaviorally, individuals may encounter avoidance, trying to escape the situation where the panic attack could occur. The fear of having a panic attack can itself become problematic, leading people to avoid places like open spaces or crowds to prevent the possibility of experiencing a panic attack. This avoidance behavior can in turn perpetuate the disorder by reinforcing the fear. A key challenge in treating panic disorder is identifying these triggers, as individuals may not always be aware of what is causing the attacks. When working with individuals experiencing panic attacks, it is essential to help them recognize their body's response to the stress and to develop techniques to lower their baseline anxiety. By addressing these physiological cues and learning how to manage them, the frequency of panic attacks can decrease, and the goal is to prevent the cycle of anxiety from intensifying, as the constant anticipation of a panic attack can actually trigger one, further exacerbating the condition. How do we treat panic disorder? Well, it involves both biological and psychological components. It's understood that some individuals may have a genetic predisposition to developing panic disorder, while others experience physiological components that may make them more susceptible. Some people are naturally more reactive to stress, and this can contribute to the development of panic disorder, especially if the body becomes primed for panic attacks. Once the cycle of panic is established, it can continue to reinforce itself, making treatment essential. Neurocounseling techniques such as EMDR, eye movement desensitization and reprocessing, as well as EFT, emotional freedom techniques, can help bridge the brain body connection, offering relief by addressing the physiological and emotional responses to panic. Cognitive strategies like CBT, cognitive behavioral therapy, DBT, dialectical behavioral therapy, and rational emotive behavior therapy are commonly used to treat panic disorder. These therapies focus on reality testing, psychoeducation, and cognitive restructuring, which involves helping the individual reframe their thoughts and develop new, healthier ways of thinking about fear. Exposure therapy is also a critical component in treatment, where individuals are gradually exposed to their triggers and desensitize them over time. Imagery and EMDR can be particularly effective in treating panic disorder. These techniques allow individuals to mentally process their fears through repetition to reduce the power that panic inducing stimuli have over them. Panic disorder can be extremely debilitating, as individuals often describe it as a feeling that they are experiencing a heart attack, unable to breathe, feeling a sense of tunnel vision, or believing that they're on the brink of death. This level of distress is one of the primary reasons why individuals seek counseling or medication, and we want to aim to normalize their experience and regain control over their lives. In panic disorder, control is often lost, especially when individuals worry about having a panic attack in public and feel helpless if they cannot get assistance. This cycle of loss of control can exacerbate the fear, creating a vicious cycle. As clinicians, our role is to provide support to help individuals process these fears, to offer empathy, and to model effective coping strategies. Evidence based treatments can help individuals regain a sense of agency and control over their lives. One disorder that you may encounter frequently throughout your career is generalized anxiety disorder. And with the long term impact of the pandemic, GAD is going to be expected to be even more prevalent, making it a very important area to focus on in treatment and research. Generalized anxiety, or GAD, is characterized by an excessive worry about almost everything. People with GAD often describe their worry as constant and all encompassing, which differs from normal everyday concerns due to the intensity and the irrationality of it. Fears in GAD are often disproportionate to the actual likelihood of the event occurring. While it is a common problem, it's less understood and can manifest differently in different individuals. GAD can be resistant to change and requires ongoing management. It extends to, it's more prevalent in Western cultures, similarly to other anxiety disorders, though cultural factors do play a role in the presentation of these disorders. When diagnosing generalized anxiety disorder, clinicians should look for specific patterns of excessive and uncontrollable worry that interferes with daily functioning. Extreme anxiety and worry that persists for at least 6 months, occurring more days than not, is a hallmark of generalized anxiety disorder. Individuals with GAD often struggle to manage their worries, which can lead to physical symptoms such as fatigue, tension, headaches, stomach aches, and high levels of stress. Difficulty sleeping is a very common problem, with worry often keeping someone awake or causing them to wake up during the night. Nightmares may also occur, intensifying anxiety. This constant worry can interfere with daily functioning, making it a challenge to perform tasks at work, school, or everyday life. These symptoms must not be attributable to another disorder. Generalized anxiety disorder is often fueled by several cognitive patterns, such as intolerance of uncertainty, positive beliefs about worries, avoidance, and negative problem orientation. So, we're going to look at each of these in more detail. intolerance of uncertainty. People with GAD often feel that worrying can reduce uncertainty in their lives. They may believe that worrying provides them with control or clarity, so that they engage in excessive planning and checking as a way to avoid the discomfort of not knowing. However, this often leads to procrastination and avoidance, as reassurance seeking behaviors and the need to eliminate uncertainty may make it difficult to move forward. The cycle of uncertainty remains unresolved, further reinforcing this anxiety. Positive beliefs about worrying. Some individuals with GAD believe that worrying helps them prepare for the future or allows them to be responsible. This belief is often tied to the idea that worrying is an essential aspect of being a good parent or a conscientious person. For instance, clients might say, I worry about my kids because it shows that I care, but the degree of worry can escalate to an unhealthy level. And this belief of useful worry can lead to excessive rumination and reinforce anxiety. Now let's talk about avoidance. Avoidance plays a key role in maintaining anxiety. People with GAD may try to suppress or distract themselves from anxious thoughts, but this often leads to exhaustion. Avoiding situations or thoughts can offer temporary relief, but reinforces the cycle of worry as it prevents the individual from actually confronting and managing their fears. And then negative problem orientation. Individuals with GAD may also struggle with a negative view of their problem solving skills. They may start to believe that they are incapable of handling life's challenges, which leads to a sense of helplessness. This can create a self fulfilling prophecy where the belief of their incompetence becomes a reality, reinforcing feelings of anxiety and insecurity. These patterns contribute to the persistence of generalized anxiety disorder, making it important to address both the cognitive and the behavioral components of treatment. So let's talk about treatment. It can be challenging, which is what brings us to lots of different treatment options that are available to us. As counselors, we often use a combination of approaches, including medication and therapy. When it comes to medication, again, we've got SSRIs, the selective serotonin reuptake inhibitors. This may look like Paxil or Lexapro. These are often very commonly prescribed to treat GAD. These medications help regulate serotonin levels in the brain, which can help to alleviate some anxiety symptoms. With regard to therapy, you know it, CBT, cognitive behavioral therapy, is one of the most effective treatments for GAD. It helps individuals challenge negative thought patterns and develop healthier coping strategies. Mindfulness based approaches such as Headspace have often shown success in helping individuals manage anxiety and promote present moment awareness and relaxation. EMDR, again, eye movement desensitization and reprocessing, can also be used, particularly if there's a trauma component contributing to the anxiety. Some other modalities include rational emotive behavior therapy, which focuses on identifying and changing irrational beliefs, and existential therapy, which may be beneficial if existential concerns such as fear of meaninglessness or death are fueling that anxiety. Narrative therapy also helps individuals to reframe their personal narratives, helping them regain control over their experiences and reduce anxiety. While psychoanalysis was once very popular treatment, it's less commonly used today, but still may be applicable in some cases. Psychoanalysis operates on the belief that anxiety results from a conflict between the ego and internal impulses. However, this approach is not widely practiced in modern counseling. In our work, we primarily focus on these evidence based treatments as they are most effective for managing anxiety disorders. There are also other less common disorders like anxiety not otherwise specified or anxiety caused by a medical condition, but these are more rare and often harder to diagnose because they don't meet full criteria for a typical anxiety disorder. All right, so we are going to switch gears here and we are going to talk about our next topic, which is obsessive and compulsive related disorders. These disorders were once grouped under anxiety in early versions of the DSM, but now they're categorized separately because they involve compulsions which stem from different areas of the brain and present unique challenges in treatment. However, these disorders are not untreatable. Even though they are pervasive, they can be quite difficult to manage. It's important for clinicians to work alongside clients to help them understand that what they are experiencing is not outside of the norm. As we all have reactions to life's challenges, these conditions exist on a spectrum. ranging from healthy anxiety to extreme forms of anxiety like panic attacks or generalized anxiety disorder. And in the case of obsessive compulsive disorder, this can range from occasionally worrying or checking behaviors to behaviors that very, very much significantly impact daily functioning. So, today we're going to focus on the most prevalent obsessive compulsive related disorders, which are going to include OCD, body dysmorphic disorder, and hoarding disorder. Other related conditions include trichotillomania, substance induced OCD, medication induced OCD, OCD due to other medical conditions, but we're not going to delve deeply into these today. There's also these substance induced cases that we may cover in more detail in the substance use disorders lecture. So, OCD and body dysmorphic disorder and hoarding disorder are often treated very similarly, as they tend to involve high levels of anxiety and compulsive behaviors. For example, BDD is characterized by excessive concern about perceived flaws in appearance and skin picking, also known as excoriation disorder. They're frequently co occurring with generalized anxiety disorder, and these conditions are often treated with similar therapeutic techniques as we've been discussing throughout our lecture here today, such as CBT and exposure therapy. So, for today, we're going to focus on those top three disorders because they are the most common ones that you'll likely encounter as a professional. So, let's delve deeper into these conditions. All right, this is the cycle of OCD. It begins with an obsessive thought, which triggers anxiety. As anxiety increases, the compulsion behavior is performed to alleviate the anxiety, providing only temporary relief. However, the compulsive behavior merely addresses the initial obsessive thought. The setting these sets the cycle in motion, and this is why OCD often co-occurs with anxiety disorders and why the two are treated together. The compulsion provides momentary relief, but the obsession quickly returns, starting the cycle anew. So this repetitive loop can be very anxiety provoking, and it can just really interfere with an individual's life. So treating these disorders is going to be a huge goal, is just to disrupt this cycle, whether that's in the thinking phase or managing the anxiety or breaking the compulsion. So it's important to distinguish between obsessions and compulsions. So we're going to do that here. Obsessions are persistent, reoccurring thoughts or impulses that can be intrusive. A person may try to ignore or suppress or neutralize these thoughts, but they are aware that these are obsessional thoughts or images coming from their own mind, unlike delusions. Therefore, obsessions are not the same as delusions. On the other hand, compulsions are repetitive behaviors or mental acts that a person feels compelled to perform. These actions are driven by the need to reduce stress or prevent a feared event or situation. Compulsions may not align with the specific theme of the obsession. For example, someone with a fear of contamination may engage in a ritual like mentally rehearsing certain actions to reduce their anxiety about germs, even though the ritual does not actually or directly involve cleaning or physical actions. So compulsions don't always directly correspond with the obsession itself. There are behaviors or mental acts performed to alleviate the anxiety caused by the obsession. So it's important to note that symptoms of OCD are not due to other psychiatric disorders. So here we're going to explore OCD as it's characterized by uncontrollable obsessions that are persistent and often inappropriate, which only increases anxiety and just continues that obsessive and repetitive cycle. For example, a person may obsess over contamination, fearing contact with germs or unclean objects, and an issue that was particularly, again, prevalent in the COVID-19 pandemic. Another common obsession involves persistent doubts, such as questioning whether an appliance like an iron or a stove was turned off. um, this doubt may lead to repeatedly checking and rechecking, which can consume a significant amount of time. For instance, an individual may check their home multiple times before leaving for work and then call someone at home to double check. OCD can involve extreme need for orderliness or symmetry. Additionally, individuals with OCD may experience aggressive impulses or thoughts, such as the urge to yell fire in a crowded room. While compulsions are often related to cleanliness, they can also be linked to impulsive thoughts or actions, and we're going to continue to discuss this. Compulsions are repetitive behaviors or rituals that the individual with OCD has to engage in to alleviate that anxiety. These behaviors, again, like we talked about, may often include cleaning, checking, repeated actions, slowness, or hoarding. The relief from these compulsions is typically only temporary. For example, cleaning rituals may be performed to reduce the fear of germs, or checking behaviors ensures tasks, like again, turning that oven off, are done correctly. Repeating tasks such as walking up the stairs multiple times or finger tapping are also very, very common. In some cases, a person may engage in repetitive folding of items or intentionally slow movements that appear almost as if the individual is in slow motion. Hoarding, while it may seem counterintuitive to the idea of OCD, can also be driven by compulsive behavior. The OCD, for a diagnosis to be made, um, compulsions must take up a significant amount of time, typically at least 1 hour per day, and they must interfere with normal functioning. And we're going to continue to talk about this. Woo, there's a lot here on this slide. Feel free to pause it if you need to. This is taken directly from the DSM. For a diagnosis of OCD, both the obsessions and the compulsions must be present, time consuming, and not attributable to another cause, such as a substance use disorder or another medical condition. Additionally, this individual cannot, uh, this, these behaviors cannot be better explained by another disorder. And it's important to specify whether the individual has insight into their condition or not, whether there are delusions present. In some cases, a tic disorder may also co-occur where the individual experiences repetitive movements or sounds such as blinking or making vocalizations. So let's talk about the origins of OCD. Psychoanalytic theory suggests that OCD may arise from attempts to suppress instinctual drives, particularly sexual or aggressive impulses that stem from the anal stage of development. However, we typically focus on more biological theories, which highlight the role of brain injury, trauma, acute illness, and chemical imbalances that either cause or exacerbate OCD. This is to support the effectiveness of SSRIs, which work by altering neurochemical reactions to reduce the experience of compulsions and obsessive thoughts. There are also genetic components, as twin studies show a high rate of heritability. In terms of therapy theories, OCD may develop through conditioning, where behavior is reinforced over time, or through modeling, where behaviors are learned from others. Additionally, individuals with a poor memory may become overly concerned about forgetting things, which can escalate into OCD over time. Family dynamics and learned behavior can also contribute to the development of OCD. So, how do we treat it? Here you go, your favorite CBT, cognitive behavioral therapy. Also, too, exposure and response prevention. This is a great one. This approach aims to extinguish compulsive behaviors by gradually exposing individuals to those anxiety provoking situations or environments while preventing the usual compulsion response. So, for example, in the case of hoarding, a person may be guided to disarm items little by little with support to manage the anxiety as it arises. While this process can be highly triggering and anxiety reducing, it is an essential step in treatment. Some other exposure techniques may include TMS, transcranial magnetic stimulation. We talked about this before in the mood disorders lecture. It can also be effective in treating OCD, and it's important to note that in some cases, individuals may develop obsessive compulsive behaviors related to their own body, which can then kind of further complicate the disorder. Let's move on to body dysmorphic disorder. This is characterized by an intense preoccupation with perceived flaws in one's appearance, which may not actually exist. The individual often holds a strong belief that they have some type of defect, even if it's not noticeable to others. This perceived flaw can lead them to feel that others are judging or noticing it, which can severely limit their engagement with the outside world. People with body dysmorphic disorder may frequently check mirrors, attempt to pick at their skin, or obsess over weight loss. Sometimes it may even be in connection with an eating disorder. This individual may go to great lengths to conceal or alter their appearance. They may use makeup, clothing, hairstyles. Unfortunately, social media can very much exacerbate these types of tendencies and drive individuals to compare themselves to others in very unrealistic ways. Common focus areas for individuals with body dysmorphic disorder include skin, hair, nose, body, and stomach. In some cases, the individual may even seek out cosmetic surgery and avoid social situations due to the fear of being judged based upon their appearance. To diagnose body dysmorphic disorder in accordance with the current DSM, the individual must have a preoccupation with the perceived flaws in their appearance that occurs at least 1 hour each day. This preoccupation can involve behaviors like skin picking, repeatedly changing clothing, excessive mirror checking. Unlike occasional mirror checking, these behaviors are persistent and excessive. The obsession with perceived flaws must cause significant distress or disruption in the person's daily life. It's important to note that the flaw is often not noticeable to others and is solely perceived by the individual. If weight is the perceived flaw, an eating disorder must be ruled out, as individuals with body dysmorphic disorder may view their bodies very differently, similarly to how someone with with anorexia or bulimia may see themselves. It's possible for someone to be diagnosed with both an eating disorder and body dysmorphic disorder, as these conditions can coexist. Let's talk about risk factors. There is a genetic component, and it may have a hereditary link. Negative life experiences, such as teasing or bullying, can also increase the risk. Certain personality traits, like being a natural perfectionist, can make individuals more vulnerable to developing BDD. Suicidal thoughts or tendencies can be exacerbated by today's society, where there's a constant exposure to social media and self-images through like platforms like Zoom. As you know, the camera may be facing us, and we often have to look at ourselves when maybe we wouldn't do that when we used to go to in-person meetings. So this can amplify the body dissatisfaction. In fact, there has been an increase in BDD cases over the past several years, likely due to the heightened focus on self-image in the digital age. Additionally, having another condition like severe anxiety or depression can further increase the likelihood of developing BDD. When treating this disorder, it's important to consider that the individual often believes the flaws that they perceive needs to be hidden. This can lead to obsessive thoughts and compulsive behaviors aimed at eliminating the perceived problem. These efforts may include seeking multiple surgeries or engaging in repetitive behaviors. Negative body image thoughts can also be intrusive in that they occur repeatedly within a short period of time, sometimes multiple times within an hour. In extreme cases, this can lead to dangerous behaviors such as eating disorder or self-harm, as the individual attempts to remove or alter the perceived flaw. These actions may result in physical harm, such as skin damage or imbalances in the body. While the prevalence of this disorder is historically less well understood, recent research indicates that rates have increased, particularly in the aftermath, again, of the pandemic. The CDC is currently conducting studies on the secondary effects of the pandemic, including the impact of increased online interactions. Prior to the pandemic, approximately 2.2% of females and 22.5% of males in the United States are diagnosed with this disorder. It's most commonly emerges during adolescence, but often goes underdiagnosed due to shame associated with this condition. This disorder is strongly tied to compulsive behaviors and feelings of shame, which can make seeking treatment quite difficult. The impact of this disorder on the individual can be very profound, leading them to feel unworthy, unloved, or unattractive. The perceived flaw becomes the only aspect of their identity that matters, overshadowing other talents or qualities. As a result, they may become so consumed with eliminating the flaw that they stop exploring other aspects of life or pursuing meaningful activities. These social relationships can suffer, and the disordered eating may develop as a coping mechanism. It's not uncommon for individuals with this disorder to repeatedly request cosmetic surgeries, such as liposuction or implants, or reshaping procedures. The challenge in treatment lies in the disconnection between how the person perceives themselves and how others see them. A clinician cannot simply tell the individual, "See what I see," and this does not address the root cause of the issue. Treating the disorder requires time, patience, and a collaborative approach between the client and the provider. The focus is often on building self-love and altering distorted perceptions and reducing obsessive thinking. By addressing the obsessive loop, where the intrusive thoughts trigger compulsive behaviors. There's a potential to break or interrupt that cycle. While it's very difficult to permanently distinguish or extinguish these behaviors, treatment aims to make them more manageable so that the individual can lead a healthier life. Some individuals may eventually manage their symptoms better, though it's not always the case. Similar to OCD, treatment focuses on managing symptoms to the best of the person's possible ability, allowing individuals to function more effectively. Life stressors can cause resurgence of symptoms. Um, so, these are going to be some very important things to take into consideration. So we talked about treatment, but again, I'm just going to show you a slide here. The same treatments continue to pop up time after time. We see CBT, cognitive behavioral therapy, DBT, dialectical behavioral therapy. A key aspect in treatment is improving the individual's self-image and self-esteem. Psychoeducation for both the individual and their family is going to be absolutely essential, particularly if the person tends to focus on those perceived flaws. It's important to work with caregivers to prevent reinforcing those negative thought patterns. For example, if someone with BDD is about to eat something and the caregiver asks, "Are you sure you want to eat that?" This can amplify that distorted thinking. Additionally, it's crucial to avoid comparing the individual with BDD to others. Instead, focus should be on emphasizing their strengths and building their self-esteem, which can help reduce obsessive thoughts and promote healthier perceptions. As with many disorders in this classification, these treatment approaches are responsive to interventions, and this leads us to the final area here, which is hoarding disorder. You often will see this in the media. If you remember back to the show Hoarders, it is important to differentiate this disorder from common behaviors like clutter or collecting or living in poverty. Hoarding is not the same as having excessive items or trash in the home due to financial constraints. A person who collects items, even in large quantities, did not necessarily have a hoarding disorder. So, similarly, general clutter or disorganization, which may stem from other conditions like ADHD or dementia, are not the same as hoarding. So, to clarify the distinction, think of hoarding as a condition where the accumulation of items interferes with daily life and functioning, whereas collecting involves the deliberate and probably very organized acquisition of items that hold personal value. While collecting has become less common in recent years, individuals who still collect often have a significant attachment or a meaning to these items that they gather. So, as counselors, our role is to really understand the specific behaviors and the motivations behind these actions to provide appropriate treatment. So here again, hoarding goes beyond collecting. I like this image because I think that just seeing it visually really gives you a much better idea of what we're talking about. So, hoarding is a compulsive behavior that creates a significant disruption in the person's life. Collecting, on the other hand, typically means acquiring items with a clear purpose. Individuals may discard or sell items that they no longer need. They tend to keep their collections very organized and well maintained. In contrast, individuals with a hoarding disorder accumulate items and rarely, if ever, get rid of them, and they may retain items with no practical use, often don't trade or discard things, and collecting is often a very pleasurable hobby for many, such as coins or stamps. Here, that looks like VHSs, remember those? So, hoarding is driven by a compulsion that can severely impair an individual's ability to live a functional and organized life. As we move into the DSM-5 criteria for hoarding disorder, this includes persistent difficulty in discarding or parting with po- possessions, regardless of their value. Individuals with a hoarding disorder may accumulate items that hold no practical or sentimental value, such as something like an egg carton or other seemingly inconsequential items. The difficulty in discarding items is often driven by a strong urge to save them or distress caused by the thought of letting them go. This results in the accumulation of a large number of possessions, which can interfere with functionality of living and workspaces. In extreme cases, living areas become so cluttered that they're no longer even usable. It's important to know that individuals with a hoarding disorder, this is driven by compulsive thinking and behavior, not by a desire to keep things organized. Compulsions are fueled by obsessive thoughts, leading to an ongoing cycle of accumulation. In many cases, it is a third party, often due to safety concerns, who recognizes the need to intervene and address the hoarding symptoms. Additionally, hoarding symptoms are not due to a general medical condition, nor are they exclusively related to another medical or mental health disorder. Hoarding disorder is a condition that often begins in early life and can continue across the lifespan, generally worsening with each decade. The first symptoms may emerge around ages 11 to 15, and individuals may hold on to things like holding on to pieces of paper. By the mid 20s, symptoms begin to significantly interfere with daily functioning. If left untreated, these issues may progress to the point where they become clinically significant. Often being diagnosed in their 30s, hoarding symptoms are particularly prevalent among older adults, with the highest rates being diagnosed of hoarding disorder in the ages between 55 and age 90. Clean outs of hoarding spaces can be very traumatic and harmful if not approached carefully. The media often portrays these situations as necessity for immediate intervention, showing scenes of people's homes being cleaned out as though it's a quick solution. However, this approach can be very distressing for individuals with hoarding disorder. These cleanouts they can feel very, very overwhelming to the individual, and the individual feels as though there's been a huge loss, especially when the person's entire world is being taken away from them in a very short period of time. Such actions are typically carried out by third parties, such as children, caregivers, other family members, or even a professional service, and it can be very deeply traumatic for the individual who has this disorder. Hoarding disorder is a long-term issue that requires a lot of patience and ongoing treatment, including medication in some cases. It's crucial to recognize the person's attachment to these possessions, no matter how difficult or unsettling it may seem to others. It is real and it needs to be treated with empathy and understanding. This disorder often presents safety concerns such as unsanitary conditions, poor air quality, risk of falling, particularly in our elderly clients, and the presence of pests. However, many interventions should proceed with care and compassion. A clean out, while sometimes necessary, is not a one-time fix. People with hoarding disorder need to continue to have support and unconditional positive regard throughout the treatment process. So this is our last slide here. We're just going to talk about treatment. We talked about cleaning out hoarding spaces, and it's crucial to understand that this process must be approached with care and sensitivity. Motivational interviewing is a key to help individuals with hoarding disorder feel ready to make that change. The goal is to guide them to a place where they are open to change. This is one done by fostering a supportive and collaborative environment. Motivational interviewing helps individuals recognize their readiness to change, but it's important to remember that change is a gradual process. Harm reduction is another important approach when dealing with hoarding. In many cases, it's unrealistic to expect to completely eliminate the hoard or extinguish the behavior within a short period of time, whether that be a week, a year, or even 5 years. Instead, harm reduction focuses on small, manageable steps that prioritize safety and well-being. For example, cleaning pathways to ensure access to exits in case of an emergency, improving air quality, removing items that may pose physical danger, such as items that could fall and cause injury. Harm reduction allows individuals to feel a sense of control over their environment while treating them with dignity and respect, providing the time that they need to continue treatment. Here we have cognitive behavioral therapy, again, everybody's favorite, DBT, dialectical behavioral therapy. These are both effective treatment methods for hoarding disorder. As we talked about before, the team-based approach can be very beneficial, and this may involve a prescriber such as a PCP, a psychiatrist, a counselor, and an in-home assistant, with frequent visits to maintain safety and address the disorder. As we talked about, SSRIs can also be a very helpful approach when it comes to medication. So there are lots of essential treatments that need to be carried out, and doing so in a very thoughtful way where we continue to give the individual ongoing support to ensure the best outcomes for individuals with hoarding behaviors. So that's all we've got for this lecture. Thank you for your time and attention, and I'll see you in the next one.